Welcome to the Thinking Practitioner Podcast,
a podcast where we dig into the fascinating issues, conditions, and quandaries in the massage and manual therapy world today.
I'm Whitney Lowe.
And I'm Teoluca.
Welcome to the Thinking Practitioner.
Teoluca here. Books of Discovery has been part of the massage therapy education world for over 20 years. Thousands of schools around the world teach with their textbooks and digital resources. In these trying times, this beloved publisher is dedicated to helping educators with online-friendly digital resources that make instruction easier and more effective in the classroom or virtually.
And I'm Whitney Lowe, and Books of Discovery likes to say learning adventures start here. They see that same spirit here on the Thinking Practitioner Podcast, and they're proud to support our work, knowing we share the mission to bring massage and bodywork community enlivening content that advances our profession. So check out their collection of e-textbooks and digital learning resources for pathology, kinesiology, anatomy, and physiology at booksofdiscovery.com, where Thinking Practitioner listeners save 15% by entering Thinking at checkout. Hello, Till. How are you today, sir?
I am very good, Whitney. Thanks. Nice to be here with you. How are you doing?
I am doing okay, doing better. I've been ill for the last week or so. I had a very unusual case of pneumonia that I am coming off of. So,
Yeah,
I had an interesting little experience with that.
Well, I'm glad what was interesting about it?
Well, it was interesting, always interesting, going to the doctor and doing things and watching the healthcare system work and watching my own symptoms and things like that. And I was just extremely ill for about 5 days with very high fever, very serious chills, fatigues, aches, body, aching, all that kind of stuff. And I went, to get a COVID test thinking like, God, this is just weird, these symptoms I was having. Yeah. And went to urgent care and it came back negative, and still sick. A couple of days later, went back again, and the doctor started running a group of tests, and I have pneumonia with no cough, no runny nose, no sore throat, no upper respiratory symptoms at all, which was weird. And so that was really interesting. And he said, he had been humbled by that condition numerous times of seeing it act weird. So that was an interesting and fascinating little process to go through there.
No fun though. Yeah, it can take all kinds of forms. I mentioned that I have some history getting over that too. So I'm glad you're able to join us today. I'm glad you're on the mend and feeling better. Yeah. I'll try to take it easy on you today.
Please do. Please.
All right. Nice. Okay. Because you proposed an interesting topic. You wanted to talk about orthopedic special tests. Did I get that right?
Yeah. So, it's been kind of an interesting topic, bandied about quite a good bit across social media and some other platforms as well. And I thought we should handle this a little bit here too. So
we should. And especially how does it relate to the hands-on manual therapy, massage therapy world that we talk about?
Yeah.
But so let me just launch in. I'm really looking forward, by the way, just to picking your brain about this. What do you mean, or what do we mean by special orthopedic tests, orthopedic special tests?
Yeah, so these are tests that are usually designed to increase our likelihood of recognizing a particular orthopedic pathology, be that carpal tunnel syndrome or tennis elbow or whatever it is. There's a lot of ways that you might just, see if someone has wrist pain or if somebody has elbow pain, but you do want to try to narrow that down as much as possible. And so over the course of the last, I don't know when the first special orthopedic test ever came up. That'd be an interesting trivia question for somebody to figure out. But, over the last decades, there have been hundreds and hundreds of these tests that have been developed. The key thing is a great deal of them, in my opinion, go back to the original theoretical models of James Cyriak's with something that he called selective tissue tension paradigm, where you try to selectively apply a force to a local tissue in some way and see if it elicits pain, indicating that there's a particular problem with that tissue. And so they took that idea with special orthopedic tests and just found out, what kinds of things stress the involved tissue in carpal tunnel syndrome when it's present. And they found, a number of different procedures would do that on a really regular basis. And after a while, they found it being, frequent enough that this person would decide to say, okay, I'm going to call this, after my name or whatever, and name it the Phelan's test or the Tennell sign or what the so-and-so test,
So
the
those
Thomas
are
test. So,
the Thomas test. Those are examples of special orthopedic tests that in those cases are used specifically to try to assess or identify carpal tunnel issues.
yeah.
Gotcha.
So, I really like to say, they tend to be used to try to identify those things frequently. And this is something we'll talk about in a good bit more detail. I think they're important to try to rule out or further refine your understanding of things. But what's come to pass is that frequently they've been used to shortcut a lot of the other evaluation process, and jump to an understanding or jump to a suspicion about something being there when the evaluation isn't actually as thorough and comprehensive as it could be.
Okay, so maybe you're saying maybe having a test could shortcut or cause you to abbreviate some of the other things you do to learn about what's going on.
Yeah.
In a way that may not be helpful.
Yeah, absolutely.
Okay, I mean, do you you mentioned the Tennell sign, the Phelan test. I'm thinking of the Lasig test or the straight leg raise. There's just some classics out there in the literature. And you said there's hundreds and hundreds of them. Do you think it's important for massage therapists to learn these? I mean, these are, we're quoting these right out of physiotherapy or orthopedic medicine.
Yeah.
How about massage therapists and manual therapists? Do they have a place for us?
I do think they have a place for us. And this is, I've sort of debated about a lot of this stuff, for decades myself, and really, I mean, kind of backtracking on this a little bit, I think I may have told this story on the podcast before of how I kind of got interested in this stuff. But, it started for me probably 6 months into my massage practice. I opened a practice in a medical office building because, we were sort of told, if you really want to start getting into the healthcare system, start networking with doctors and that sort of thing. And so I did. I opened up an office there in this building, and I was very young and green and did not really know what I was doing a lot. And of course, my training was pretty limited at that time. It was just 6 months out of massage school. But in any event, gave brochures to all the docs in the building and all that kind of thing. And so this woman came down to see me one day. She said she had been sent down by one of the doctors, the general practice doctors up there, who he, said like, okay, well, let's send somebody down to this guy and see if it helps. And she came in and she was obviously in a tremendous amount of pain, back pain. And so I started going through the whole interview thing with her, filling out the form and things like that. And I was trying to tell her, how to get undressed, get on the table, and I would come in and start doing it. And she's looking at the massage table and kind of looking back at me, and I could see what's going through her head is like, how am I going to get on that table?
Yeah.
And I'm recognizing that this is going to get to be a real challenge here. And so she did find a way to get onto the table, and what I didn't allow to her to hear the words and the phrase or the rotating thing going on in my head was, I have no idea what's wrong with this woman. And I don't know if I'm going to help her. I don't know if I'm going to hurt her, but I need this client really badly because this doctor just sent her to me. It's the first person he's ever sent down here. And I can't just send her back.
Yeah.
Like, I don't know what's going on here.
Yeah.
And so, my treatment goal for that day ended up being, let this woman leave my office without worse pain than she came in here, and I will definitely consider that a success. And then as soon as she did, I started, I was like moments later into the books, like I got to figure out how do you figure out what somebody's back pain was? And it was at that time too that I also ran into Benny Vaughn. And, he was the first person who had been teaching continuing education workshops that I had attended that ever started talking about assessment. And so that just clicked with me as something that was really relevant for us to learn how to figure out what was wrong with somebody. And so back to your original question about special orthopedic tests, in many instances, they have a great deal of value because they can certainly rule out a lot of red flags and, help you refine a direction of understanding of what's happening.
Okay, so they can rule out red flags. They can help us understand what's happening.
Yeah.
But just back to your story for a second, because I think that's emblematic in a way of the way our field is evolving, where most of us weren't trained in that deductive process of trying to figure out what's happening with the client or patient. Most of us were trained in protocols and routines of some sort, and we just apply that. I'm remembering my own beginning stories of finding myself in a room with somebody with a fairly serious situation and like, okay, which routine do I use now? And really pulling out of the hat or just trying to even guess. And thank goodness, so many of them worked that allowed me to have enough encouragement. But you said that really drove you to hit the books and really start to understand these things. It's also making me remember that's basically how I met you, because I was scheduled to teach a class on the shoulder, and someone says, okay, so could you focus it around conditions of the shoulder, which was actually kind of a radical idea, because otherwise I was just thinking, shoulders are cool, let's talk about shoulders. I'm thinking, conditions of the shoulder, like reasons clients would actually be coming to see us. That's a cool thought. This would be middle 90s or something like that.
Right.
And so I just started searching the literature. I don't even know if it was Google we had back then. Maybe it was Yahoo or something, but I was just doing internet searches and came up with your name and like, oh, wow, here's this massage guy who actually wrote an article about, I think it was carpal tunnel or something. Maybe it was thoracic outlet. It's one of those. And I thought, okay, this is pretty good. So he's like, this guy, Whitney, is finding things in the orthopedic world and helping translate them to our manual therapy world. That's pretty great. So I think it was actually through you that I got introduced to some of those. Back in.
And certainly, my background was a bit unusual too, compared to a lot of other massage therapists in terms of learning environments, because I spent a lot of my early years in an orthopedic clinic. So working side by side with orthopedic physicians and physical therapists and that sort of thing. So I learned a lot of what they were doing simply by, watching them and following them around and asking a ton of questions. And so, recognizing, thinking, hey, this could really be relevant for massage therapists, and that maybe not so much.
Well, you've really made a unique contribution and found a niche for yourself in standing for that process of the critical thinking, of using assessments to think it through, because again, that wasn't part of our tradition for many of us. And so it's really interesting that you're talking about these now from this point of view, and you're dialing it down to where you see them being useful. Ruling things in, ruling things out. Is it time to talk about any other pros before we get into the cons?
Well, one thing I would like to mention in terms of this, and this is kind of touching base, you and I just got through participating in a panel discussion on critical thinking and sort of reasoning processes. And this is one of those places where I think that it really shines the value and the necessity of developing some types of critical thinking and reasoning skills. And in relation to orthopedic assessment tests, special orthopedic assessment tests. For example, I wrote this article back in when was it? I've got to look this up here. 2008. Yeah, it was 2008. So wrote this article in 2008 for the Journal of Bodywork and Movement Therapies on suggested variations on standard carpal tunnel assessment tests. And where this came from was me working with a number of people and finding, like, in a standard orthopedic assessment test, like a Phalen's test, where in the Phalen's test, if you're not familiar with this procedure, you just place your back sides of your hands together and press them against each other. And that bend in the wrist right over the carpal tunnel.
Like a
pressure.
reverse prayer position. So my fingers are pointing down, the back of my hands are together, and I press them together. Okay.
And in that position, that presses on the median nerve in the carpal tunnel and usually will exacerbate and aggravate those symptoms, indicating carpal tunnel involvement. But let's say your carpal tunnel is not really as severe yet. but maybe there are certain things that you do that might make those symptoms come up. Well, at the same time, I was really heavy into exploring David Butler's work on neural mobilization and Michael Shacklock's work and all that kind of stuff, and thought, well, what if we modify some of those standard carpal tunnel assessment positions? For example, with the Phelan's test position, instead of holding the hands in front of the body with the rest of the upper median nerve relaxed, what if you did that with your arm all the way stuck out to the side and your head bent to the opposite side, which puts tension throughout the whole neural structure? And what I found is that then those carpal tunnel symptoms often would show up where they wouldn't show up in a standard carpal tunnel assessment test.
So you were stressing the nerve a little bit with the position, like a neurodynamic kind of tensioner.
Yeah.
And you were using that as a kind of assessment to see, is that nerve sensitized? Does it produce
Yeah. So I'd use the Phelan's test position with the hand, bent all the way out to the side with the rest of the nerve tensioned that way.
Yes.
And, and then take the tension off by bending the head back to neutral and see, does the wrist pain stop?
Yes.
And often it would. And so thinking through how might I vary this standard assessment procedure helps me, pinpoint if there is some type of local tissue driven nociceptive problem there, like, inflamed median nerve getting compressed, or is this maybe a large scale neural sensitization issue somewhere else? So from that instance, or knowing some basic orthopedic special tests to start with and alter those positions is really valuable. And so that's why I still think it's really helpful for massage therapists to know some of these procedures and then to be able to use them appropriately.
Okay, great. So yeah, if you hang out with physical therapists or physios at all, that's their bread and butter. I mean, most of them are very well trained in the conventional repertory of them.
Yeah.
And at least even if there's debate in that field about their usefulness, most of them are still getting tested on it.
Yeah.
And that becomes the kind of working vocabulary of a lot of physical therapy.
Yeah.
At least in the US. I don't know about other countries, but yeah, these tests become the kind of the collective wisdom of that set.
Yeah.
So are we ready for some of the ways that they've come under scrutiny or people are questioning their usefulness?
Yeah, I think that's a good place to jump into next here.
Yeah. What are some of the cons of those, or why are they perhaps being questioned or controversial?
Well, a couple of things come to mind, and there are several of the things are outlined really well in a nice little editorial piece that was in the British Journal of Sports Medicine in 2017. Its name caught my eye, and I had I've got to read this to see what it's about. The paper is called Orthopedic Special Tests and Diagnostic Accuracy Studies, House Wine Served in Very Cheap Containers. I thought, what in the world are they talking? What in the world are they talking about? So I got to go look this up. But the analogy that they use.
Chad Cook, by the way,
Cook
and
Eric Hegedus,
co-authors.
Co-authors of excellent orthopedic assessment text, and they've been doing this stuff for just years, so they're heavily into it.
Yeah.
But they put together some really good concepts and ideas in this piece. First of all, they were saying orthopedic special tests have become house wine. And the analogy they use is like when you go out to dinner, you could go down the wine list and start thinking, what would pair well? I'm going to have lamb tonight. What's going to pair well with the lamb? I've got to think through this and, figure out what's going to work well. Or I could just order the house wine, and that'd be the easy way around it. And this is what happens a lot with the special orthopedic test, is that people say somebody comes in with shoulder pain and they just start going through a bunch of shoulder tests with them,
right,
without going through the other pieces first that really need to happen for a comprehensive evaluation.
For example, what are some of the other pieces did you?
So, for example, did they go through, active and passive movement and resistive testing of numerous positions and find out, certain of these things hurt during active movement, but not during passive movement? Or, what was the pattern?
Yeah.
Like they hurt during abduction, but, not during external rotation or something like that.
Specific
and they didn't look for some of those specific patterns that would point to, something else that might be happening in there. And they jump to, using, these special orthopedic tests as a means of identifying something rather quickly, which is very helpful in the healthcare system when you're a physician who only spends an average of 7 minutes with a client to
Yeah.
do some of this kind of stuff just rapidly, and it's yep, got it. That's what you got.
Right. So
So
they really do, they become probably so ubiquitous because they do really lend themselves to defining something, giving it a name, which
yeah,
is something you got to write down with your ISD and description, whatever it is. They help you just have the feeling like you know what to do. Okay, now I know what it is, and now I know what to do. So that's the promise. But some of the critiques in this paper were it's like house wine. It's one size fits all. Is that the critique, basically?
yeah, just that it allows you to skip over the other parts of making decisions that you really
I
should
see.
be going through and just go for the easy answer.
Which also
Um,
might include history, some medical circumstances, personal circumstances, all those kind of factors in
yeah,
there
yeah.
as well.
And so I've seen this a lot, in terms of the way these procedures have been used in the massage therapy world is in
Uh-huh.
a similar fashion. When people learn some special orthopedic tests, they'll jump right to doing some of these tests and skip over those other important parts of the evaluation process, which I think often illustrate or make something show up that doesn't show up at all in the orthopedic test.
Mm,
And the other part of this problem is, many of these tests aren't actually that reliable. When they started doing some of the evaluation studies for, how accurate these tests really
mhm,
were across a broad spectrum of the
mhm.
population with certain conditions, um, they didn't turn out to have such great accuracy. So that's one problem. And the other, another issue that they brought up in this little editorial piece is that, the accuracy studies that are often run on these orthopedic tests are compared against some other types of gold standards, which oftentimes aren't
Yeah,
themselves that accurate. So now you're trying
themselves.
to make something determine how
So it's,
accurate it
yeah,
is.
this is,
I was
yeah,
just gonna
well,
say,
that's, I mean, the validity of a test is a big topic. So you're saying that some of the critique in this paper, maybe in general, is that one, they may not be that accurate. Maybe they don't really reliably show what they say they show. And then even when they do, what they're compared to might be complex too.
yeah,
I read the figure, I'm just pulling it out of my memory, but I think it's somewhere between 4% and 7%. I think it's Chad Cook said 4, and someone else said 7 in terms of the number of standard orthopedic tests that could be reliable, said to be absolutely reliable, and compared to something that could be validated another way.
yeah,
So
yeah,
it's a really low percentage of these things that actually have an evidence base behind them, it turns out.
right. And that becomes a problem if you're putting a whole lot more of your eggs in that basket in your evaluation process and not doing a bunch of other things. Now,
Hmm.
if you're using that test as a piece of the puzzle and you're using that as only a small percentage of your evaluation thought process, and you're
Okay.
recognizing that it has accuracy limitations, then there's still, value in having that be part of your evaluation process. But the trick is, and the seductive trick is, they tend to be things that make us think that we've really nailed something down when we may not have.
You're bringing to mind a debate that was very much alive in my days at the Rolf Institute when I was teaching at the Rolf Institute. And it's probably just a fundamental paradigm clash in our ways of understanding things. But on one side of this debate was the idea that what we're learning is essentially mysterious and acquired through experience and is so complex and multi-causal that trying to reduce it to cause and effect is bound to fail. That basically you couldn't reduce something like manual therapy down to a bunch of tests that say, if I do this, then I'm going to know exactly what to do because it's just too complex.
Yeah.
That's one side of the debate. The other side of the debate was all of us who were trying to learn this stuff going, okay, so given that, what the heck do I do? How do I even know where to start? Give me something that I can try so it'll give me a sense of what needs to happen next. And I remember the teachers there at the Institute at some point were identified as being in one camp or the other. And eventually that led to a kind of political split in the Institute. It was painful for the people involved, but The ones with one point of view went to one school, the ones with another point of view ostensibly went to another school, but of course, it's not quite that simple. But this is a really fundamental schism in our ways of understanding. Can we reduce it to simple, if I see this, then I do that?
Yeah.
And then is using multiple tests enough? Because that's often the caveat that's given. You say, okay, so learn these tests, but do several because that'll help cover it. But you're saying there's another level of complexity too, which is really understanding the context and the history and some other factors around that.
Yeah. Now, let me introduce another thought into this, which I have found interesting to ponder, because I began thinking about this when I was, looking at all this stuff, questioning some of the value of these tests over the last couple of years. And you and I had an interesting, podcast discussion about this when we were talking about client expectations and outcomes.
Yeah.
I don't remember our episode number that we did that with, but that was, we had some fascinating discussions about how client expectations can really enhance the outcomes. Now, the idea when you start going in your
23, 23.
Excellent.
Sorry, I just looked it up.
I'm glad you did, because I want to be able to reference that. And who was our guest that we had for that discussion? It was
that was Mark Bishop.
And Mark Bishop, right? Yeah. So Mark's, had wonderful research that he's done on these whole issues around client expectations. And so you start going through a number of orthopedic tests with somebody, and it's kind of like, hey, this person's got to really knows what they're doing. They're like asking me all these questions, because I will tell you, numerous times clinically, I have had clients ask me, how come nobody ever did this with me before? When we're going through the assessment and the evaluation process, because I do a really thorough and comprehensive assessment. And I think that has a lot of benefit for client outcomes, for people feeling greater confidence in what I'm going to be doing with my therapeutic interventions with them as well. So that's another potential benefit that they may have that's not often recognized and not often talked about.
Mm-hmm. Yeah, well, there's a process of listening and methodically working through with someone that has an effect in and of itself of just getting the details there, getting the story established. So taking the time to do that, I can see being really therapeutic in its own right.
Yeah.
As well. Mm-hmm. Okay. So say some more about what could be the most effective ways to use these. Anything else we want to check off? How should we use them before we do more about how not to use them?
Yeah. So I just want to encourage people, if you are going to use them, to basically don't use them in a vacuum by any means. Let them be a comprehensive part of a bigger picture puzzle that you use in your evaluation process. They shouldn't. I don't agree with just. I have heard some very prominent educators say some things like, "Oh, I don't do any of that kind of stuff anymore. I just, start, working with my client's sense of discomfort and work from there." That's okay if that's your approach. That's not what I find to be most effective for me. I still think there's a lot of value in finding in certain types of conditions, finding instances where it's potentially beneficial to do this and have it really help somebody by finding the nature of what's going on with them. So I think there's a lot of benefits and ways that this still can be done here.
Great. And so how should we not use them? I mean, I want to throw in the diagnosis word in there too, because how is this different than diagnosing? If we use a special test and say, oh yeah, positive for pain, carpal tunnel, I got it. How is that different than diagnosing?
Yeah, and that's something that we haven't touched on here, and it's a really important distinction, because there is that seductive temptation for a lot of practitioners is to get into the thought process of using them that way. And I will also say too, in watching a lot of the social media discussions about these topics, a lot of massage therapists will just jump back in and say, no, I don't use these tests because we don't diagnose. And that reveals a fundamental misunderstanding of what they're used for, because there is a big difference between assessment and diagnosis. Assessment is a systematic process of gathering information. And that's what we're doing with this test. Now, if you take that Phelan's test and you tell your client, oh, see, you got pain in your wrist, you've got carpal tunnel syndrome. Now you've crossed the line because you've told them a particular condition and named it, and that's giving it a diagnosis. You may think in your head they have carpal tunnel syndrome, and you say, oh, you've got pain there. Okay, well, let's see if we can work with some of that discomfort with the manual therapy that we're going to be doing here. You don't ever have to tell them any particular named condition, but that's a seductive place that people often get into and often misunderstand how to use those procedures and end up doing that kind of stuff. And you can end up getting yourself in trouble by doing that as well.
Well, getting yourself in trouble, but also it's enormously complex to tell someone they have something, or even that their positive test means that it's a likelihood that they, quote, have something. And there's some really good reasons why most of us have injunctions against doing that, because of that communication process can be helpful or it can be harmful to be told you've got something going on. And yet I'm with you, Whitney, we are as practitioners, we're gathering information, we're making guesses, working hypotheses all the times for ourselves that guide our work, and we can dialogue about them with our clients and patients. But the difference there being I'm not telling them what's going on with them. I'm using these as starting places or working hypotheses that I go check and test for myself.
Yeah. And that's a really key thing for people to remember is how you do that and how you frame it and how you look at those kinds of procedures, because you can give people, really, I don't want to say damaging, but let's just call it detrimental, nociceptive messages about things going on with them by saying, oh, you've got a positive Phelan's test. That definitely means there's something going, you've got your nerve is compressed here. And we don't know that for sure, actually. So we can say, oh, you've got increased pain there. So let's look at this. There could be, a number of different factors that might be producing that. So.
So we don't look for them for an absolute diagnosis. We don't use them in isolation, saying, if I see this, then absolutely I do that. Any other things we don't do with special tests?
I think those are the big don'ts. And I would say too, don't put so much weight on them. And this is painfully obvious that this is not, this is not a beneficial business perspective for me to say, don't put so much emphasis on the stuff that I spent a whole bunch of years writing a book about and selling it everywhere to people with all these special orthopedic tests in it and everything. But the reality is I don't do that anymore to the same degree either. So I really have moved away from a lot of this stuff that is in the book that way and don't put as much emphasis on it as I used to, for sure.
Okay, I think we've kind of filled out why, but say a little more about that, what that was like for you over the years, because you put a lot of energy into cataloging and clarifying and building a model on these. Tell us about what that's like for you now.
It's challenging. It's very challenging for me because there's that quote has been bandied about on the internet quite a bit about it's hard to get somebody to change their understanding when what is it when their income depends on it or something like that. I can't remember exactly the way it goes, but right. And I've seen that with a lot of people having difficulty making significant paradigm shifts around the models that they've taught for years. And that's one of the ways in which that's been challenging for me, which is that, I've been all about assessment not all about assessment. There's a lot of emphasis on, the treatment that follows through with that. But assessment's been a big part of my focus in my business. And also introducing and teaching massage therapists a lot of these special orthopedic tests. I spent a lot of time learning about them, and I spent a lot of time learning them in these different environments. So that's been one of those rug pull out from under the feet kinds of things to cause me to reframe a lot of what I'm doing and a lot of what I'm talking about. But it has also led me to refocus more on what do I think are really the valuable things that people need to be learning, and what are more valuable things they need to be getting from things. Because I saw this happen a lot in the classroom, in the education world, is that there's a lot of emphasis on just trying to learn these tests, and that's trickled down into entry-level training programs where they're teaching a lot of these orthopedic tests and some of these entry-level training programs now. And man, students are so overwhelmed with amount of information that they need to know for their licensing exams. And what you're doing is teaching them these tests without really developing the complex clinical reasoning that should come before you even perform the test to figure out what's happening. And so what you end up doing is, teaching them to memorize things that just become a process or procedure that they don't really understand.
As well as, I'm just thinking too about the subtle distinctions between specificity, and sensitivity, and all of the things that a result can mean or not mean, and how to use those, how to take it beyond beyond just, if I see this in the test, then I should do this. All the considerations around that are really a large undertaking to understand all that. So you're saying that, maybe they don't belong in entry-level education, or at least if they are there, what do you think?
Well, this has been a really hard question for me as well. And again, I sold my book to schools for years for programs to teach that stuff. But I really don't support that idea any longer, that those things should be taught in entry-level training programs.
Okay, cool.
Just for those reasons that we just talked about, is that a lot of this actually for me comes from me studying a lot about education and recognizing things about cognitive load and curriculum development, and how to put together things where people can sequentially actually get something and keep it and have it last.
Yes.
And recognizing there's a big difference between information dumping and educational experiences that tend to be more long lasting.
Well, we've been talking about it, but let's just take a second to name it. What should people be learning instead? Where would people's energy go instead?
So here's where it should go instead, in my opinion, is, and this comes from also watching this, in teaching assessment and continuing education workshops for several decades now, which is that, we start going through some basics, and I'll say, hey, I want to go through some exercises here about, basic range of motion practices, active motion, passive motion, and manual resistive tests, which are very simple ideas. And most practitioners are taught this kind of stuff in their entry-level training programs. And so I'll ask a question, how many people, know how to do these procedures? And, probably 90% of the hands will go up in the classroom and say, great. All right, good. So we don't need to go over that a whole lot. So let's put this into practice, and I'll give them a worksheet, and I'll, have them go through this worksheet. I said, all right, now do these procedures, active flexion of the shoulder, passive lateral rotation, and resisted medial rotation. Now, if your client has pain with the first two of those, but not the second or something like that, I'll make up this pattern. What does that mean?
In terms of a muscle involved or something like that.
They will struggle with this. It will take them long periods of time to go through that. And you can see the frustration of we never learned how to do that. It's like, that's what you should be studying. And, by the time we go through this whole worksheet, there's these light bulbs are going off for people thinking we learned how to do range of motion in school, but I never really understood how to use it. And what does it really mean? And so this is what I think.
How to use it to deduce or get a hypothesis about which structures might be involved and where I want to go.
Yeah, even just very simple going through those processes. What does it mean if it's painful when you do this and painful when you don't do that? And you'll probably recall back when we did the shoulder jam, as part of my presentation, I showed a bunch of these charts that we use that are just, what happens to these tissues. So what I did is I ended up going back, and I did this for our online program, is make these tremendously detailed charts of what tissues are stressed when you do active shoulder flexion, and what tissues are stressed when you do passive shoulder flexion, what tissues are compressed, what tissues are stretched, what tissues are elongated.
Yes.
And these, then, like what would possibly cause pain when you do all these things. So now that's where I encourage people to put their attention is, if you want to really do this, take a look at some of those kinds of charts and start saying, how would I figure these things out, like in a simple evaluation with my client, and look through what procedures cause those sensations. And then maybe you can just quickly look it up in the chart and say, like, how, what might be involved here. And so,
yeah. So the basic skills there are really pretty fundamental. It's a clinical reasoning process that asks the question, let's find out what's going on before we start throwing techniques at it.
yeah,
Let's use specific movements, active, passive, etc., resisted, unresisted. And then you've done all this work on your charts where we can actually just go look up and say, okay, so if this is the movement, then this is probably the structures involved. People with instinctual understanding of anatomy can get there on their own too, but you've done a lot of the hard work there. I'm going to put a link to that shoulder jam presentation in our show notes, I think, because you really excited people there. I remember in the jam too, because people go, oh, wow, you mean I can do these simple movements and then look it up in Whitney's chart and see like what structure's involved.
Yeah.
That's so great.
Yeah. So that, again, is another further elaboration of thinking through from an educational perspective of what's really information that's relevant. And, how do I pull something like that out of there? Because the truth is, the complexity of looking at those patterns is not easy.
Yeah.
It takes understanding a good bit of, biomechanics, kinesiology, anatomy, and all those things put together to put some of those concepts and ideas together. But if you want to get good at looking for local tissue involvement when that's the cause, that's a good way to do it.
That the complexity there makes it really tempting to say, oh, I don't diagnose, so I'm not going to do that. Or I work intuitively, not cognitively, so I'm not going to do that. Or I kind of know what works, so I'm just going to kind of go do that. All those reasons we come up with not to have to think things through. And I just want to make a pitch for it. It doesn't have to be so complicated. I mean, you have done a lot of the hard work in there, and basically it's some really simple principles. You're using those as pain provocation tests. You're finding out what makes the troubling sensation happen, and then reverse engineering it, or even using those combinations of movements to come up with a treatment strategy.
Yeah. And thank you for saying that, because that is absolutely true, is that it doesn't have to be hard in many instances. And in many instances, it's not that difficult. I do, and this is just the way that I work mentally, I like having a framework to sort of organize my thoughts of what happens with, the results of these different procedures. And that's just happens to be how I work. Other people work different ways. And that's the beauty of the world. But I do think that there is, especially when you got, the clients that are really trying to nail down, like, I can't, get anybody to help me figure out what's wrong with my shoulder or my neck or whatever. That's when it's particularly helpful. Because it is allows you to really drill down into those kind of details.
Well, I see it getting interesting to people at some point in their career too. I mean, maybe some people will never find it interesting, but many people after 5 years in, 10 years in, whatever, start to realize, okay, my routine, my shotgun routines, or throwing everything at the wall and seeing what sticks routines help a lot of people, but maybe I could get even more efficient, more specific, and even better by getting methodical, or getting very intentional in the ways I'm using these things to determine my best guess treatments.
Yeah, absolutely.
Okay, so we've talked about some good things. Anything else you want to make sure we cover before we wrap it up for today?
Yeah, I think we've hit that pretty thoroughly there on the things that I wanted to kind of call up. I would encourage people to take a look at some of those things that we'll mention in the resources. The article, the Cook and Hegedus article was a really good piece. You had asked too about, where do people learn some more about, tests, some of these different tests and how to evaluate whether or not they're good or not.
I can just hear the student in my class at this point saying, okay, you've told me all the reasons why tests, I don't need them, but now which tests should I use? Where do I get those tests? They sounded pretty interesting to me.
Yeah.
So what would you say to that person?
There's a couple of good resources out there. We mentioned the Chad Cook, for example. He's got a really good book out there, Orthopedic Physical Examination Tests. That's a good one out there. There's a really comprehensive, thorough assessment book that David Zulak did, Clinical Assessment for Massage Therapy. And David's a practitioner out of Canada, and this is a handspring publication. A really thorough, comprehensive recourse in there. So again, very rarely do you get these comprehensive orthopedic assessment resources aimed at massage therapists. So this is a really good, thorough one he did there.
Well, and I just want to wave your flag. Of course, you're still offering that whole repertoire of tests that you've put together over the years, and you're evolving and going. That's still available, isn't it?
It is, and in fact, we that stuff is all inside our online program, and all of those orthopedic tests are in video in there now, which I think is so important because a lot of these procedures, you see them in the textbooks with pictures and descriptions, but you may not understand exactly how to move the person through the test just the right way. So that's why I felt like the videos were so important. So I really cut the number of tests down that I wanted to emphasize people to learn, because I didn't think it was necessary for them to really go and memorize hundreds and hundreds of these tests. So I really kept it to ones that I thought had better accuracy levels and also were really pretty relevant for people.
Can you name some names? Are you willing to name some tests that you've found useful enough to leave in there, reliable enough to leave in?
Oh yeah, sure. Like some of the the ones that are particularly valuable, like the straight leg raise is almost always included for people as a really valuable thing.
Lessig, test of Lessig. Yep.
Yeah. I've gotten a lot of benefit by the upper limb neurodynamic tests that have been developed that focus on upper limb neural pathologies. In combination with looking at some other things. There's some other things that are, particularly valuable in sort of nailing down some, making some discriminations between things. Some of the, patellofemoral tests that, just basic having people squatting down, which is considered a special orthopedic test. And again, this is one of the places where I get to talk about, changing the way you do a standard testing procedure, because I found like doing palpation of the extensor retinaculum while you move the knee into flexion with a load on it is a really good, valuable way to reproduce and see if that's, causing those kinds of things. So,
if that's the place of trouble, if that's the place that's doing compression or friction or something,
so
that's great.
Yeah. So a lot of those kinds of things are particularly helpful and valuable. Especially, things like the straight leg raise test and some other things that might help you really pull out something that's a serious red flag that needs to go be seen by somebody else. So
there you go.
Yeah.
Well, you're just helping me appreciate too how important a role those tests have played in my own development to go beyond for myself from just applying routines or recipes into really being able to tailor what I do to what the client's coming in with, and how it's so important just to remember they're just one factor, but they can help me to begin that process of a biomechanical narrowing or a biomechanical hypothesis that then I can go experiment with and work from.
Yeah. Mm-hmm.
But I'm gonna go ahead and put the link to your online program too in the episode resources. I think that's really a great one for people.
Yep. All right.
Anything else you want to cover today?
I think we've done a good job of tailoring a discussion on some of these key things to think about around the special orthopedic tests.
That's great. Me too. Yeah. And this is episode 52, and you know what that means, right?
52.
52. Now we're playing with a full deck finally.
Oh.
But all we need, or you could say all we need
Beforehand,
is,
we were only paying
yeah,
partial day.
exactly. Or you could say at this point, all we need is a couple of jokers, and then we're going to be good.
I think we've had a couple of jokers from the start. Yeah.
Pretty good. 52 episodes. It's been a pleasure.
Indeed,
I'm
it has.
looking forward to the next 52 or however many we do.
Yeah. This episode, do you know what's the air date on this episode?
Slated for, you never know what's going to happen, but slated for the 17th of November, 2021.
I can't remember. I think you did put on the schedule there. We were getting up really close on our 2-year anniversary.
Yeah, that'll be
right?
that'll be a episode or two later. We're going to do an anniversary episode. Yep. Mm-hmm.
Yeah. So
winding down.
Cool. Yeah. All right. Well, thank you very much for that discussion today, for all those great questions. As you can tell, I love talking about this stuff, and I hope that's helpful for some other folks as well.
I've enjoyed it. No, and thanks for sharing all that you have and having the time today to go over that.
Yeah.
I want to thank our sponsors, all of them, but our closing sponsor is Handspring, and just about them in particular, like we mentioned, they actually have a great book on orthopedic testing. We'll put the link in the show notes. But when I was looking for a publisher for a book I was wanting to write, this is many years ago, I ended up with 2 offers, one from a large international media conglomerate and the other from Handspring, a small publisher in Scotland run by 4 great people who love great books and love our field. To this day, I'm glad I chose to go with them, Handspring, because not only did they help me make the books I wanted to share, the Advanced Myofascial Technique series, but their catalog has emerged as one of the leading collections of professional level books written especially for body workers, movement teachers, and all professionals who use movement or touch to help patients achieve wellness.
And Handspring's Move to Learn webinars are free 45-minute broadcasts featuring their authors, including one with you, Till. So do head over to their website at handspringpublishing.com to check those out. And be sure to use the code TTP at checkout for a discount. And thanks again, Handspring. And thanks to all our sponsors once again. And we offer a special thanks to all of our listeners. We thank you all for hanging out with us again here today. You can stop by our sites for show notes, transcripts, and any extras. You can find that over on my site at academyofclinicalmassage.com. And Till, where can they find that for you?
The episode show notes, etc., on our site are under advanced-trainings.com. If there are questions or things you want to hear us talk about, email us at, it's info@thethinkingpractitioner.com, or look for us on social media, just under our names. My name is Till Luca. What's your name?
My name today is Whitney Lowe, and you can find that on my social channels there as well. If you will, follow us on Spotify, rate us on Apple Podcasts. That does help people to find the show. So please go follow over there, and then wherever else you happen to listen, Stitcher, etc. And wherever you happen to listen, and do tell a friend. And
if you go to one of our sponsors, tell them that you heard about it on us, because that helps everybody too. That helps us realize that we're helping spread the word in a helpful way.
That does. Sponsors like to know that when that's certainly very helpful for them as well. And of course, if you're unable to find us in any of those locations, you can grab a flashlight, a transistor radio, and find a local cowboy and strap them to their saddle, and you can pick us up on satellite radio. So we're available there as well. Okay.
Thank you, Whitney.
All right, sir. Enjoyed it. And we'll talk to you again here soon.
See you later.
Okay.